As previewed, we'll have Rob Lookstein discuss the real-world applications of AI and PE.
Thanks, Alex, and thank you, Danya, for that fantastic sort of introduction to this concept. So I'm going to bring you to the future of clinical care for acute pulmonary embolism. All right, I'm an absolute zealot about this, and I've been working on this now for several years, but literally this is where we are going to go for treating acute PE, and this is, in my opinion, the future of advanced diagnosis and triage of all cardiovascular emergencies. These are my disclosures. So by way of history, and again, Danya touched upon this, AI has been around for a long time. We all remember, those of us who are radiologists, that the CAT scanner itself basically could tell you whether there was a PE. But obviously those results only went to the diagnostic radiologist. And the diagnostic radiologist is not going to decide whether the patient needs surgery or needs TPA or needs an endovascular revascularization, et cetera, et cetera, et cetera. And so that was sort of the first foray, 15 years ago. There was been numerous iterations that have been allowed sort of the reading radiologist to be notified at his workstation. There's been a lot of work in artificial intelligence to try and sort of triage that subtly and say, is this a central clot? How much strain is the right ventricle on? And then about 4 years ago, these mobile phone apps came along, which could literally sort of ping the physician and notify them that there was a central large PE. But as all of us knows, we don't treat every single large central PE, and so it really had to be tuned. And we've luckily tuned that now, so we have very, very high accuracy, and I'll share that data with you. Then you need to obviously, on a mobile setting, regardless of where somebody is in the emergency room, on the floor, in the operating room, cath lab, et cetera, that everybody's communicating about this urgent diagnosis at the exact same time, sharing their opinions and their concerns about where the patient should be triaged to. And then very, very recently, at least in our institution last year or so, we have full integration to the electronic medical records. And so we're literally able to say, is this not just an intermediate risk PE, is it an intermediate high risk PE, or is it a high risk PE? And again, that's been really transformative because we are really able to categorize the patient, figure out what we're going to do, hopefully enroll them in a clinical trial, but that's happening now. There are 3 vendors that have FDA-approved mobile devices. I think they're all wonderful and great, and I'll touch base upon them very, very briefly. At our institution, we've had a long-standing partnership with Aidoc, and a lot of the data I'm going to share with you is predicated on our long-term relationship with Aidoc. This is the Rapid platform. And again, you see that you can see the CAT scan images on your phone very, very nicely. You are able to calculate the RV to LV ratio. But again, all of us know that only really puts you in the intermediate category. It really doesn't tell you anything specifically about whether or not the patient needs to be substratified into intermediate high or not. This is the Viz platform. Again, very, very, very similar, very robust, different color scheme, but again, very, very dynamic. And again, Aidoc, and the one thing that, again, I think is wonderful about Aidoc is that we're fully integrated with the EMR. And so you see this sort of virtual chart there in the 4th panel that shows the vital signs. And the vital signs are updated constantly, and you can see trends on your phone. So is the patient teetering to become hypotensive? Is the patient trending to become more tachycardic? Is the patient becoming more hypoxic? And then again, you have all the relevant biomarkers listed there, and then all the relevant surrogate studies. And this happens instantly. There's no active participation by the clinician. This just shows up on your phone within seconds once the scan is completed. So there's absolutely no delay whatsoever. Again, Danya referenced numerous of these articles, so there is research, but honestly, in my opinion, this field is moving so fast, it's almost hard to generate data that's reflective of what's happening now. And again, we've really realized, again, the future of advanced cardiovascular diagnosis and triage now. Any data we collected is almost years old by this point. So logistically, again, when we turned this on, our entire team was amazed. They couldn't believe how easy the data was going onto their phone, and that we could communicate and figure out, well, this patient needs to go to the ICU, this patient should be discharged, this patient needs to go to the OR, et cetera. Everybody bought into it, all right? Again, it's amazing how automatic the data is aggregated, and I'll show you multiple mechanisms to curate that, so you can have weekly, monthly reports, quarterly, annually, to share with your team, to show your chief medical officer, to show your CFO, et cetera. We give the the vendor real-time feedback so we can really reduce the number of false positives. And I can tell you right now, we have almost a 99% negative predictive value. This is a very, very powerful algorithm, and we really don't have inaccurate diagnoses anymore. On an obstacle point of view, we're a very large healthcare system, and this took a couple of years to build. We're covering 8 hospitals across the greater New York area. It lives in radiology, and the server is housed next to the radiology PACS system. And you need radiology IT support, which for many clinicians, whether they're surgeons or cardiologists, they might not have easy access to radiology IT, and so you sort of need to have that to install this and work the way it should work, it must work, to really realize what the potential future applications are. The issues regarding PHI are not subtle, and so you are carrying on an app PHI, and I think we're all aware of how the cybersecurity concerns that your organization has. Again, we've been able to navigate that, and again, we're very, very grateful for that. And then the issue of notification fatigue becomes a real issue. We are here, we're literally at the end of the curve where I really feel we're able to, again, get all the relevant clinical information in seconds to make an acute diagnosis and figure out what the plan's gonna be for that patient. As I said, we're spread out all over the greater metropolitan area, so to have everybody in the system instantly notified that there's an intermediate high risk or high risk PE and be able to decide, are we gonna transfer this patient? Where are they gonna go? Do they need an ICU bed, et cetera, really helps us. Obviously, the more standardization that we have, reduction of variation is tremendous valuable to the patient. This is an unmet need. And so, again, the majority of clinical sites across the United States don't have a pulmonary embolism response team. These patients are, in my opinion, underdiagnosed, undertreated. Escalation is happening rarely. But again, we've seen at least evidence that there's a dramatic reduction of length of stay with the introduction of the PERT, and certainly with this rapid AI triage mechanism. So again, from a historical perspective, when we looked at this before we turned on this app, this was the stepwise process. The CAT scan would come up, the radiologist would read it, the radiologist would call the ED would hem and haw about what to do. Maybe they'd call the pulmonologist, maybe they'd call the cardiologist, maybe they'd call an interventional radiologist, consults, phone calls, emails, texts, on and on and on and on, and then eventually, something on the order of 4 to 5 hours later, possibly even 6 hours later, we would make a decision about whether or not an intervention was needed. So again, Aidoc has developed rapid triaging for acute stroke, rapid triage for acute dissection, rapid triage for acute pulmonary embolism, and again, you're able to get feedback in real time every week, every month about how good your organization is doing. There's a dedicated triage protocol for dedicated CTPAs. There's an incidental protocol. So if you have an abdominal CT scan and you catch it on the edge, or a neck CT scan, it'll notify you as well. And then again, it automatically calculates the degree of right heart strain. And so all this information is curated and aggregated, and you can have it sent to your desktop, sent to your email, so you have all the data about all these patients going on, which obviously leads to improved care. We program the notification so that we're only being notified, to reduce notification fatigue, central clot in the main or lobar branches or a saddle with an RV to LV ratio greater than 1 with positive biomarkers. And so again, that puts you at a minimum into intermediate high risk or possibly high risk, and those are the only cases that we are notified. Just in the last 18 months or so, since we've turned on the entire package, we've analyzed 62,000 scans, and of those, the notifications are only 365. So we're getting about 1 a day. All right. Now imagine if you were getting 2,200, which was all the positive PEs, you would absolutely throw your phone into the garbage. And so again, this is so transformative and disruptive that we've been able to figure this out. Again, the high risk accuracy, extraordinarily high, not just our experience, this has been repeated at the University of Chicago. It's all curated on your phone, and it's all stored on the server in your institution that you can download and be able to aggregate. And I'll show you a couple examples of it before I close out. Our time to intervention or to triage and disposition has been reduced by 40% because it's all happening within seconds on your phone from the moment the CAT scan is actually completed in your patient archival system. These results have been replicated across the United States, which has been great. This is automatically curated data on how many cases you're seeing every week, every month, every year. which hospitals they're going to. Are they men or women? What's their ages? Are they intermediate low, intermediate high, or high risk? What time of day are they coming in? How many have RV to LV ratios greater than 1.5, greater than 2? How many have positive biomarkers? And it allows you to do quality assurance and make sure that you're treating all of your patients in a timely manner. And again, this data is generated automatically. All you need to do is just press a button and it downloads directly to your desktop. We also have screening reports, so we can recruit every single patient who comes in into all of our clinical trials that we are doing. This has transformed our research infrastructure, so we know that every single case is being screened and identified for potential trial participation. Again, we've diagnosed 1,500 patients over the course of the year. This is how it's organized and aggregated, and you can mine this and curate it however you want. Just a very, very brief thing. Our accuracy of being able to pick up a sort of relevant per case is 90%. This is our first iteration. And so it's, again, a very, very, very powerful tool. So what does the future hold? Instant protected diagnose and triage of every single PE in your system on your phone. Everybody on your team is able to interact with it within seconds. There is no delay whatsoever. All of these automated reports, which again are automated, all you need to do is just ask them what you want, is sent to your desktop, sent to your email, sent to your server, and allows you to enroll every single potential patient into all the prospective research that is going on. We meet with our CMOs and CFOs regularly to explain to them how we're improving the quality of care, improving outcomes, reducing length of stay, et cetera. And again, the future beyond this is going to be deep learning, looking at all these therapeutic options to see which patients are best treated by all of our therapeutic options. Thank you very much for your attention.
Yeah, that was a great talk and really appreciate your passion for this. Do you think it will reach a point that hospitals will be at liability for a delay of care, particularly with the moderate to high or high risk, if they take too long before they start enacting care? Is that coming down the pike?
So very briefly, this is already mandated for acute stroke, for LVO stroke. It is mandated. And one of the impetuses for this, to having it be mobile so that all the endovascular teams and the intensivists could diagnose them immediately, was predicated on that. That is JACO mandated, CMS mandated, et cetera, et cetera. We do not have level 1 evidence for the rapid treatment and certainly endovascular therapy for acute PE. There are numerous prospective randomized trials going on. If those trials are positive and it gets into the guidelines and we truly can distinguish what the benefit is of these advanced therapeutic options, I absolutely agree this will become mandated by the hospital.